Now I'd like to hand off the podium to my colleague, Dr. Stefan Becker from Vienna, who is actually using these tools in day-to-day practice, and he'll talk to us about what really makes a difference, how we affect outcome. Dr. Becker.
Thank you. Thank you very much. Anbam. All right, just let me set up the pointer. There you are. All right, thank you very much for inviting me here to talk to you. I'm the rare bird here. I'm an orthopedic and spine surgeon. And I'm not really mainly on MRI for my diagnosis. Why? Because it's not very helpful unless there's a herniated disc. That's why I'm also a chiropractor. I studied chiropractic for 5 years, became a chiropractor, and I feel quite confident doing a 30, 45 minutes chiropractic segmental examination to get the real diagnostic. So you see there's still a missing link between imaging and examination. I'm going to talk about this now. These are my disclosures. I'm the first commercial user of this Nocimed technique in Europe. Why are we doing this now, spine surgeons? I'm a member of the International Educational Board of North American Spine Society, and we get pressure from the patients, we get pressure from reimbursement telling us that we operate too much. Operation fusions are not worth doing. You see here since 1992, there was no difference between conservative treatment or a fusion or the 2010 clinical study. More than 30,000 patients shown that the fusion is not better than just decompression. On the other hand, here in Germany, I'm German, but we have several clinics in Europe which I run. This is a statement by the head of the German Spine Society saying 4 out of 5 spine operations are unnecessary and just being done because the hospital or the doctors are earning money. There's a reaction of insurance companies, at least in Germany. This is one of the biggest, the Techniker Krankenkasse. They analyzed 19,000 fusions, found it out in the second opinion network, 85% are unnecessary. And now they are thinking about having a second opinion before you fuse and before you operate as a spine surgeon in order to get reimbursement. So, what are we missing here? We are missing the right diagnosis. We are missing the right segment. We are fusing very often the wrong segment or putting total disc replacement in the wrong segment. You know, total disc replacement is not reimbursed in most of the European states. It has been, now it's withdrawn from reimbursement because we put it mainly on the wrong level. So talking to the World Health Organization in 2013, they told us spine surgeons, where do we need to go? Where do we need to go in spine development in orthopedics? So you see here the future areas defined by the World Health Organization. The first one is established of biomarkers to get a better diagnosis in 2013. Then the search of risk factors and so on, biomaterials for disc replacement therapies like biological materials. I'm going to talk this just roughly. And the stem cell research for disc regeneration. Okay, so that's the consequence. Now we have what are the consequences? We have now a viable scan, all right? We can be very precise about which level we can treat with a very high confidence here. What's our next step? Me as a spine surgeon, why should I investigate the biology of the spine if I amputate it by doing fusion or total disc? Makes no sense. I don't need to investigate the biology because I'm not caring about regeneration of disc. I just amputate it and fuse it. And that's the different approaches now which is promoted by a lot of interventional radiologists in Europe together with our spine surgeons, our what we call integrated spine surgery, where we I haven't fused for 10 years now in our centers, where we look into restoring biology, cell-based and all of that. Because we have since 10 years those techniques available. I go through this just roughly. We are running together with our interventional radiologist friends ECR courses all over Europe with those techniques which are on the market in Europe since 10 years. The first is we can now denervate the disc. You know, the basivertebral nerve is innervating the end plates, the upper and the lower end plates. We can denervate this with ablation in the disc or with vertebroplasty. Just published a study together with our interventional friends from Torino, 178 vertebroplasties for Modic and 176 success out of 178. patients. So we can actually denervate and treat MODIC with ablation or vertebroplasty with resorbable bone matrices. We just need to know which segment to denervate. Here you see it here, that's the denervation tool, which is available here in Europe. And so this is the vertebroplasty with this study, what I told you, 176 out of 178 success. So here it's quite easy to see where the painful segment comes from, which is obvious, but most of the time we miss it if we don't see it like that on the MRI. The next is intradiscal hydrogel, also since 10 years on the market in Europe, where that's a very nice thing where we actually buffer the lactate. We put it in within 30 minutes, 1 hour. It swells and it buffers the acidity. So again, we don't know where to put it because we are missing the Nocimed can, which we now have. And intradiscal PRP. I'm doing PRP in orthopedics since 22 years, since about 10 years on the spine. We've developed a nanomolecular filtration system in order to get enough cells into the nucleus. Now we get 10 million cells per microliter of thrombocytes in the nucleus. And we know that thrombocytes are bacteriostatic and bactericidal in most of the epidermal flora. So that's probably a very good treatment tool also for the Propionibacter. Escherichia coli, streptococcus stuff, everything's killed by PRP. So that could be the therapy here in the future. And of course, the RF ablation techniques in order to shrink the disc and to take away all these herniated issues. But now with these US-based techniques where we also can actually close the posterior gap, the little rupture here in the disc, and do annuloplasty over here. So we have those things available. We just need the right diagnostics for it. And finally, of course, the conservative treatment. Yeah, with electromagnetic fields, anti-inflammatory, low laser light, or we develop for our own hospital groups some anti-inflammatory plant-based drugs for inflammation on the disc and also for restoring the osmotic pressure in the disc. All right, so I developed a treatment algorithm for my clinic group where we look into lactate positive and negative patients, proteoglycan normal or negative patients, or at least decreased proteoglycan, and normal and positive and negative disc height, and then it gives you actually where you are, exactly the treatments, what we are realizing in our clinic group since 10 years, and now we are much more focusing on the Nocimed scan. So, and of course, herniation, non-herniation. Just give you an overview about my outcomes. These were our first 30 Nocimed scan patients. First of all, we need to know, is it reliable? Is it good? Am I learning something from the scan? And the 30 patient was really helpful. In one patient, even could rule out that it is a lumbar issue. It was an SI issue in this patient, and all the 29 others were really confirmed lumbar patients. I have already operated 5 patients. One is on the list next week for me, and we did conservative treatment 24 cases, and probably another 5 I need to operate. The conservative treatment is not that helpful. So let me just show you the follow-up of my first 5 operated patients. That's the overall. You see the VAS back was decreased in all of them. After 4 weeks, the VAS leg also, and the ODI improved more than 50%. So really good outcome, much better than I had before with 85% failures of fusion. Of course, I didn't fuse. What we did actually have here patients, female 50-year back pain with intermittent radicular pain of the L4 left side with a little HIZ here. Okay, so obviously I see there's something on the L4 root here, but in order to make sure, I make a scan, and the scan confirmed actually what we see here, what I also thought. There's something wrong on the L4 nerve root here. You see a very high lactate level with a normal disc here, and this was a little too small voxels to get everything, but this is probably a transition zone, probably some problems there with transition to the sacrum. Very important for me is also proteoglycan. Proteoglycan is a marker of the stability on the disc. The lower the proteoglycan, the higher the risk of rupture, the higher the risk of herniation. And you see here her proteoglycan was only 36%. which is not good. So for this patient, because she also had intermittent radicular pain, according to the algorithm, a nucleoplasty was performed. This is not only shrinking the disc, but also increasing the collagen matrix in the nucleus in order to avoid further rupture. So the outcome was the VAS back has significantly improved, and the legs also, because with this nucleoplasty technique, we also flash the disc with sodium chloride, which in that case probably is buffering the lactate. So she is happy after 4 weeks after the operation. Another one, 44-year-old, radicular pain and back pain. All of those were non-facet patients. I always excuse the facet excluded with manual therapies, with investigation. You see here this herniation here, more midline, and then some changes up here. This Nocimed score gives you not enough voxels on that one, but this is obvious what's here. I wanted to see what the other discs, the value of the other discs. Yeah? I want to see what's going on with the other discs, and we see here just normal scores here, but you see here a really decreased proteoglycan score on L3, where as a surgeon I now can tell her, okay, I do L4, and I wait until you have a ruptured hernia on L3. Patient won't be happy coming 5 years back and she has herniation on L3. Once I have her in the OR under local CD analgesia, I can do another level. So what I did in her case was actually this microsurgically assisted nucleoplasty on L4, 5, because it's quite a big hernia here, and another nucleoplasty in L3 and 4. And I told her that I will rescan her with Nocimed in 2 months and see if your pain has improved and the lactate level also. If not, on that level I will do a PRP in order to enhance the regeneration of the nucleus if the pain persisting. But she just came back this week, and now 4 weeks after the operation, and she was even, back was improved, the leg was improved, she was happy. So I probably won't inject the cells in 2 months, but I will scan her later and we see the outcome. That's a 44-year-old chronic back pain. Those are the patients where either they have some genetic disposition, they have some sports, some activities. This doesn't look healthy for a 44-year-old. Huh? He's quite too young. And what I do here, this guy is on the fusion list from L2 to S1 in the university here in Vienna. And they didn't want to have a fusion, so he came to see me, did an Nocimed score, and you see here high lactate levels on discs where you would not even, you wouldn't even suggest that there's a high lactate level. It's L2, 3, well, 3, 4, you would see probably because of the modic, but what's going on here and here. So this guy has high lactate level, also L2, L3, and that's the proteoglycan score. As I told you, for me it's very important in order to avoid herniation, and even where the lactate was very high, the proteoglycan is still okay, and here we have proteoglycan issues, okay? But according to the algorithm, not a high disc. If I have a high disc, the risk of herniation is much, much higher than with this crushed disc, of course. So I treated the patient with PRP on 3 levels, which were those 3 levels here, in order to buffer the lactate, in order to increase the proteoglycan. And it took him about 3 weeks, not improvement. I got him back every week, and now this week he started with the improvement. You see the VAS back from roughly 9 to 3.5. No issues here, and just now. But we know from PRP it will take up to a year to regenerate the disc. So he's just starting to be better, that one. Okay, another patient. I'm still okay here, yes. A 42-year-old deep lumbar pain. All right, not radical pain, just deep lumbar pain. Of course, as a reflex, I worked in 8 universities in 4 countries up to the second in command in the span unit. I would have used him immediately, L5S1. Okay, so looking at the Nocimed, L5S1 is obviously too small for the voxel to scan. 4.5 and 3.4 are okay. And the proteoglycan level on 4.5 is also diminished on that patient. So I treated the patient with PAP on L4-5 and L5S1. I can't put a hydrogel stick in 5S1. This is too small. And I try not to mix too many techniques together, so I just did PAP, L4-5 and 5S1. And this was the outcome after 4 weeks. Back improved. Leg, no issue. There was no issue before. And also the ODI is much better. And the patient is good. And I'm sure that he still will get rid of these two in the next weeks. All right, so another one, 40-year-old chronic moderate back pain. You see here now HIZ over here in the midline, which is not causing any irritation to any nerve root. And here it's okay, but it's a 40-year-old patient, which I consider young. The older you get, the younger they are, of course. And that's the outcome here. You see a moderate lactate level and 4-5. 5S1 is not the issue. So if we can't measure it because it's too small, that's not the issue clinically. The issue is to look at two healthy segments in order to learn more about the healthy segments. So he got SSC. A little bit moderate to mildly decreased lactate level and a okay level for proteoglycan 4-5. So this was a typical conservative patient treated with electromagnetic laser, nutraceuticals, and physio and all of that. If persistent, do a 4-5 and 5S1 PAP. Hydrogel is contraindicated because of the HIZ. We have seen some dislocations in HIZ in patients with hydrogel, so that's contraindicated for this patient. So that's a typical chronic moderate back pain conservative. So see, we are not operating on all of them. Huh? So that's a typical 174 chronic back pain. That's the typical fusion patient where you fuse everything and then they will wake up and have SI pain and adjacent segment pain after 1, 2, 3, 4, 5 years, and you end up fusing the whole lumbar spine. So really increased lactate levels on the 3 lower segments. Really, and he had chronic back pain, taking a lot of medication. Obviously, not measured proteoglycan levels down there, but I'm not so much concerned about this disc. There is no herniation risk. I'm a little bit concerned about this disc here. With this not measurable proteoglycan level, I'm not concerned of that one. So that's a typical patient just to get rid of back pain where I do vertebroplasty or ablation of the basic vertebral nerve. And that patient, he's on the operation list, and I think in 2 or 3 weeks, do a vertebroplasty here, here, and here, and at the same time a PAP and 5S1 in order to increase here some proteoglycan for that patient. The risk of herniation when you're 74 is very low, so you know this, so that should get rid of his pain, but I haven't treated him yet. And that's one of our most difficult patients, not listening to a doctor, not listening to professors and to anybody else he meets, it's me. I also wanted to know what's going on with my own disc. I have some slight back pain on and off. That's my disc. You see little HIZ here, nothing else. But I wanted to see my disc health. And that's the point for Nocimed. It's for the health of this. I want to see how I develop, whether I have a risk of herniation next years. Lactate level was really elevated. But as I said, my pain is not that much. But I have good features in my unit, so they treat me anyway. The proteoglycan also. So I'm quite confident that I won't go to one of my colleagues to have an operation, and I treat myself with nutraceuticals and so on. I get by, and I have, standing here, I have no back pain compared to you. So, and I know where it comes from, and that's a good thing. You might get a scan also. I know where it comes from. So on these patients, of course, what we do, we have, in order to bother this, we are not shrinking a lot. We know that back pain is related to osmotic pressure to fluid intake. So I drink now a lot. I take these anti-inflammatory nutraceuticals, I do more sports, and so on, for my disc health. So, gave you a little overview where we are. We actually, Nocimed for us is for the interventional radiologists in Europe and those spine surgeons who are looking beyond fusion, is the tool to find and to evaluate and to use the new biological approaches, starting from cells to ablations to hydrogels and all these new things that are coming on the market or are on the market already. And I thank you very much for your attention, and we'll go wait for your questions.
So, Dr. Becker, you can stay up there. I'll stay over here. This way you can have your podium if we need it. Any questions for either one of us? So I have a question for you. I was focusing really on more of the straight Nocimed scores, which were really heavily weighted by the presence of abnormal metabolites. You seem to be more focused on the health of the disc and the healthy markers. Can you translate for me and for the folks in the room how your SI scores relate to the scores that I was showing?
Yeah, well, so we know that proteoglycan is a marker for disc stability. What's what I said, and the lower the proteoglycan, the higher the morbidity. And we are looking to hypermobile discs, which are then stressing the facet joints. This is some coming from the chiropractor examinations, yes? And if you have a really high mobile disc, you run into much more hyper compression of facet joint on one side. So when you lift something up and suddenly have this back pain, which is one of these issues.
It sounds like what happened to me this morning.
Huh?
It sounds like what happened to me this morning.
Yeah, exactly. So, yeah, you may look into that. But as we have all these parameters available, and also probably the propionic acid, why should we use it in our therapies if we can do something else? So that's why I look at all the values, not just the lactate. We know that we have to buffer the lactate, but also on the proteoglycan. How can I increase the proteoglycan? There will be some new cross-linkers on the market in the next months, years, to increase the proteoglycan cross-linking and those things. So that's for me the disc health, everything together, not just the lactate level.
How long have you been using these physiologic tools in your clinical practice?
What do you mean, how long?
How many years, months have you been using these tools to determine which patients get treated? We have, as I said, I do about PRP since about 10 years, and so on and so on. Early on, and hydrogels also early on, we just relied on the Modics. Yeah, the Modic 1 or 2. You look for Modic 1
because that's
changes,
the only
yeah.
thing where it's really an inflammation you inject and treat those levels, also with vertebroplasty or ablation. And only about 8 out of 10 patients are pain-free, 80%, which is not that good, because, we do it since 10 years now, these things. But now I think I'm much better, and I see beyond Modic. Modic for me is already too late, because then you have a edema in the end plates, your end plate disruption, or the study from Jeff Lotz, you know these things, you have endoteres, and you have ingrowth of the nerve fiber, so that's the end. We want to do something early for our young patients.
Well, it sounds great. And you feel that this technology that gives you these spectroscopy scores, you clearly believe in them. How much of a difference do you think it makes to have this in your hands as opposed to just relying on the Modic scores?
We hope that we get more than 90-95% success with this already, because everything we did, never got more than 80. Yeah, unless we inject every disc prophylactically, but with the cardiology studies, to inject a healthy disc, that's a problem. Here, at least I have a reason to treat the disc, which I also can propagate, can show, see, there's something, a deficit in that disc, and then I can treat it. Before, probably the lawyer will sue me if I treat the disc, and the radiologist tells me it's a healthy disc. Huh?
Have you ever used discography in your practice in the triage of your patients? Have you ever used it, or do you still use it, discography?
No. Discography is since 2002-3 banned in our societies, orthopedic societies. We cannot do it anymore. Because I spoke to Kevin Foley, a neurosurgeon from Baltimore. He said the most important aspect he gets is when he puts the needle, not in the disc, but in the skin of the patient, and the patient jumps off the table so he knows what the diagnosis is. So the discogram now, we don't use it since about, was it enough, 15 years?
Interesting. Any comments or questions from anyone? Was anyone familiar with spine spectroscopy before today? Had you heard of it beforehand? Is anyone doing discography in their clinical practices or in their practice region? Is it going on, or is it throughout Europe? It doesn't go on at all. I can't see. Did you?
Hi, doctor. I know you're a patient yourself, and I am a patient too. We were able to discuss about the sciatica a while ago, but you never mentioned about the treatment, or I just missed it. Anyway, so symptomatically, I am a sciatic patient, so I have sciatica left-sided. However, I couldn't go through MRI because I have pacemaker, and it's not an MRI safe pacemaker. So is there a way that I could be treated?
Yeah, of course. I mean, you have the radiologists here in the room. I won't tell you what other you can do. Yeah. Of course, you can do your CT scan and then all of these other tools you guys do, right? But in the end, if it's a sciatica, and we are quite good in finding out which nerve root just by doing a physical examination or by doing then EMG and nerve root conductive studies, then we actually, and if you have one there, then we can do still a CT or X-ray guided perineural infiltration to demonstrate that it's the real nerve root. And then I can go ahead and do these whatever techniques is necessary. Once I see all of these shrinking ablation techniques which are around since 1998, you can do them if you don't have a sequestrated herniated disc. If you have a sequester, of course, this doesn't work. Yes, that's the only thing. We need to rule out that you have a sequester. And here I need to ask the radiologist to help me ruling out that she has a sequester. We probably can do with CT or something else, right? Yeah, so Lawrence, you will know how to do that.
This question
right?
is directed to the young lady who just made that comment. Are you a radiologist or just wandered into the room because we were talking about interesting?
I'm a radiologist, CT, MRI.
That's great, wonderful. So this is the reason I asked, is mostly because there is increasing evidence that MR can be performed safely in pacemakers that have not officially been approved as conditionally safe. So I would suggest that if it turns out you feel you need an MRI, make sure you've exhausted all the possibilities, because again, I think some of our concepts about who can get an MRI and who can't are changing with respect to pacemakers. So work with your local teams or local advisors or even the manufacturer of your pacemaker itself and see whether indeed there might be a possibility to get an MRI. Once you're on the MRI scanner, then you would probably be limited to low SAR techniques, but I don't think that spectroscopy would fall into a difficult area as far as that goes, but you'd have to investigate that as well. Mm. But hope is not all lost.
I just have a question to you, Lawrence, about the discogram in the US. In Europe, we were taught 20 years ago that you have to actually do a discogram on a non-injured and healthy level in order to have the negative control. Is it still?
Yeah, I think that's still the nature of practice. You know, frankly, I don't practice discography, which is why I showed you a picture of my colleague. But my understanding is it is still conventional to do a controlled disc, which essentially means you're putting a needle into a completely theoretically healthy disc. Yeah. And that has effects. Again, it's a subjective test, so that's probably why in your region it's fallen into disfavor. In the U.S., there are proponents and folks that feel that it isn't the best exam, and again, it is invasive. So while it can be very powerful, it is still controversial. Some areas very controversial, and if there's an alternative that doesn't hurt, that might cost less, that deliver the same information, I think that's something to be excited about.
Yeah. Special about, I don't know how you do this provocative one with local anesthetic and cortisone, which has been or is still also available in Europe. Cortisone is actually destroying the nuclear cells, and local anesthesia is increasing the lactate levels. So well, it's not good for a disc health.
It no longer is a native state once you've stuck a needle in it. But there are folks who get benefit out of it, and really this is just a way to get that information without creating any physiological alterations. Yes, sir.
Dr. Canova, you asked Dr. Becker how this affects his practice. Turning that around in the context of, as a radiologist and in an imaging practice, how do you see this affecting your practice?
It's an interesting thing. There isn't a clamor you don't find the clamor of radiologists, beating the path to the door to find out the painful disc, because we kind of work in a vacuum. We issue reports, they have great detail, and they're very meticulous, but we're just describing non-specific findings. Now, sometimes things all point in the right direction, patients get better, but we know that the outcome benefits of what we find with spine MRI are relatively weak. So, but radiologists kind of toil away and do their thing, and really just there's a big disconnect between what happens on the surgery side or on the physiatry side and what happens when we issue reports. And I think right there you're talking kind of to the wrong person, or you're trying to wake us up in radiology that there is impact and there is untapped information that our clinical colleagues and our surgical colleagues can benefit from. And that really is the message. We work in a vacuum. We need to get more connected to what makes a difference. We need, as MRI, as radiologists, okay, and I'm in a big outpatient imaging concern, about 1 million exams a year, 300 facilities. The number one MR exam that we do is a lumbar spine MRI. If we continue to deliver such little value on those exams, they will disappear. There's a lot of what we hear, value, value, value. Where's the value? Right now, not an awful lot of value. Okay, we can't really affect outcome. If we can get additional physiologic information from our scanners, we stand to deliver better value. And when you hear how it changes therapy on the surgical side, I mean, that's what we should be after. And then perhaps we'll get better outcomes. Perhaps we'll be doing more spine MRI. I would certainly hope that we can find a way to make a difference in outcome with additional physiologic information. And, that's a fervent hope. And I think, to keep our head in the ground and think that business as usual is still going to go on over the next 10 years, I think is a tough one.